So we originally had 30 minutes. Now we have 26 minutes left for questions. And I have 2 questions per presenter. No, I don't have any question. Please line up. I probably should say something for Nancy's one of the first slides, which is kind of shocking. 60% significant trauma, 90% have trauma. I recently finished 2 studies, one in Norway with unaccompanied minors. These are kids who are exposed to war, another in Turkey with Syrian refugee children. And it could be a measurement error, but we use stressful life events measure. We didn't see this number. So the trauma level for children who are exposed to war in Syria over a 3-year period is lower than that.
Hello, I'm Norma Finkelstein. I'm on the committee, and I was really interested to see all of you mention the commonality in one way or another of the issue of substance use, both in parents and in children, and that's a lot in my field, in addiction. But Nancy, I wanted to ask you specifically, and also was really interested to hear the commonality of trauma, which affects so many of our families, not just the Native American population, but I wanted to ask specifically a couple questions to you, given the both historical and current trauma levels and the resulting use of alcohol and drugs, both historically and currently in the Native American population, and that impact on parenting, as we know. I had 2 questions. One was actually very specific. I work also in the field of FAS and FASD, and I know a lot of researchers that have been doing research in various tribal communities. I wondered if you've come across that issue and how it gets integrated at all into parenting issues in the communities. And my second is, in general, if there's been any attempts to integrate within the tribal communities the issues of substance use and trauma into parenting approaches, parenting curriculums, et cetera.
Sure. So the rates of FASD are certainly very high. And I can speak to a couple of examples. In one community I work in, they're doing a lot of work with adolescents in preconceptual health, really trying to get across the idea that you can't be using alcohol before these kids are becoming pregnant, so that as an attempt to sort of prevent the high rates of FASD. So that's one effort that I know is happening, not a significant evaluation of that, but it certainly is happening. And one other thing I would speak to, actually, which is not related to early childhood, but we're right in the process of implementing an adapted intervention for parents at the transition to adolescence, which is another critical time for supporting parents, and it's based on the Strengthening Families program out of Iowa. And one of the things that we've done in our adaptation, we worked very closely with advisors in the tribal community to ground that intervention that's got a very strong evidence base in other populations. We're trying to ground it within the culture of the community. And one of the issues that came up, Strengthening Families has, it happens in weekly sessions, and there is a focus in one weekly session on stress and helping parents and youth deal with stress. And given what we know about this community and the evidence that we have, we said we have to take it further than that. We really have to talk about trauma. Yes. And we have to help parents know how to recognize the impact of trauma on their youth. What are the signs? And it's not a therapy session, and we can't fix it all, but we have to acknowledge that this is happening, and parents need help knowing what to do. And so we have created a session that goes much further in terms of describing the impact of trauma, what it looks like, what the symptoms of PTSD are, and really working with parents to connect them to resources as are available in the community. And we're evaluating that to see, we're in the process of actually we're piloting that program right now, and in the fall we begin an evaluation. So I think there are efforts like that, and I can tell you of other things that other colleagues are doing to try to address that. But we got some pushback actually from the Strengthening Families program to say, this isn't about trauma, we can't do this. And we said, we have to in this community. We cannot not do it in this community.
There are a lot of communities that need to have that integrated in. Thank you.
And it's scary. I mean, we have extra clinical staff on hand for that week to make sure whatever brings up is addressed. But
Thank you. Krishna?
Yeah, Vishwanath. My first question is to Dr. Whitesell, and if we have time, maybe to Dr. Luthar and Dr. Whitesell. I'm coming straight from a cancer disparities meeting, and this notion, this idea, or this fact that there are, somewhere anywhere between 300 to 500 different tribes and sovereign nations is really challenging from an implementation point of view, I think. So I'm just curious, are there good models for implementation? Because whatever we come up with will fail miserably at the implementation stage. Dissemination is possible. So that's one. If you have time, maybe even just to point us to some models would be very helpful for the committee. And second, if you have time, for both Dr. Luthar and for you, if you said it, I apologize, I missed it. I didn't hear anything about fatherhood in these two, both in your case as well as in your case. If you can speak to that, that will be helpful. Thanks.
Just briefly, in terms of models, I don't think we have great models for how to implement interventions across those different communities, except I would say that the most important step is involving the community in the early discussions of that and in taking that to the community and trying to figure out what the fit is. I have a colleague who's done a lot of translational work in terms of trying to implement sexual risk interventions in tribal communities, and there are a lot of challenges, but the most successful is if it really rests on that relationship with people in the community who know what the particular issues are, and some flexibility around tweaking that intervention to fit the community. So in the project I was just mentioning, we've worked very hard to figure out how do we maintain the core principles and the core elements of an effective intervention, but then how do we introduce things that really reflect the local context? And it's very hard work. It is not quick. I don't think there's going to be a recipe that you can take out there and plop it in.
Thank you. Suniya?
Universals. The two groups of moms that I've been working with are at two completely opposite ends of the socioeconomic spectrum. So our first trial was heroin-addicted mothers in inner cities with extreme poverty, mostly ethnic minority moms and so on. Used exactly the same strategy with these physician moms and well-educated moms. Basically, is taking care of the mother. Who mothers mommy? And when mommy's taken care, what's the old saying? If mom ain't happy, ain't nobody happy? Right? So this is switching it into more positive. So that's one possible, as Mark would say in language universal. Help mom be happy. That's one. Second, the issue about dads. I did mention dads only to say that, as Aurora was saying, it's very hard to get them. Not because they don't care, not because they're not good dads, but because they're extremely busy in this case. In the case of drug-abusing moms, again, like you would say, many of them are not present, hard to reach. So if you wanted dads present in the family trial, you'd be dropping up a lot of moms, right? Our strategy in working with upper middle class families is exactly what these folks have said, is go through the moms to get to the dads. Last point, I know you cannot assume that the same parenting strategies can be used for moms and for dads. Engaging dads is a different ballgame from engaging moms. So my friend and colleague, Mary Jane Roth from Boris, has done these trials out in Africa. For women, it's the tending and befriending, like what I talked about, authentic connections. For men, for dads, it's through soccer, recreational activities, or as you were saying, the professional, get them jobs or job opportunities or training. So the idea is to think not just culture specific, but gender specific, as we're trying to engage mothers and fathers both in our interventions.
Thank you. Yes, sir, if you also introduce yourself.
Good morning. My name is Oscar Cruz. I'm coming from Los Angeles, California, doing a lot of work with families. And it's been a lot of great, thank you for your presentations, a lot of great information. But the trend that I've been seeing is this conversation about what parents should do, what they must do, what they could do, what they would do. But I think that the bigger question, I think, for the group is about the policy component, or what are the institutions supposed to be doing to creating the conditions or the opportunities for eliminating the obstacles that those families face in being able to play one role or the other. So I'm really curious more about shifting that conversation more to what should institutions be doing to create the conditions for this to happen? And in particular, I'm thinking about the cultural competency piece. We keep on thinking about policy as the program, but we know that no matter what program sometimes we implement in some of the schools that we work in, parents don't feel welcome. They don't feel value. There's no relationship between the institution and the families being served. They're not valued as assets. They're not valued as people who can actually do something, agents of change. So I don't know if you have any comments about really switching that conversation about what are the institutions should be doing, because we can have multiple days of conversation about what parents should do. But I think it is about the policy that interests me a lot.
Thank you so much. Aurora, maybe you may respond to this.
Oh, okay. You know, there are several. Well, first of all, I think the educational system is a very important system. I think for many poor parents, they need some education beyond high school, and for many, they don't feel welcomed in the school system. And also policies. There are a few policies that allow them to support them financially while they're going back to school to get training for a career in the labor market, which all of them need if they are to get out of poverty. There's no way to get out of poverty unless you win the lottery or you have a job. You have to do one of those two things. And to get a job, you have to have a certain amount of training. Now, for the men, at least the men that I've worked with, most of them have a criminal justice record of some kind or another. And they indicate that it's very difficult, really, for them to qualify for jobs because that history follows them. So there needs to be some loosening up of the way in which we use those kinds of histories in terms of people who are attempting, really, to do the right thing. Because many of them indicate that they start out as very young guys doing things that they should not have done. And now, when they see themselves as being, and they're really still young, they're like in their 20s and 30s saying that they have learned something, but they have a history that they can't quite overcome. And it's very difficult for them to do the things that they would like to do in terms of supporting their families. So they have to go to those job markets that are outside and they have to continue really to do criminal justice type things, to commit crimes in order to get money. And that's very sad. And I don't know what kind of federal policies could do I don't know differently.
If I just add one thing before you, there is a new initiative around the colleges at NYU as well. One of my students leading there, which is eliminate the box. Eliminate the box. So when you enter school, you also have to check whether you have a record or what. And there are more than 300 universities now stop asking that question. So initiatives like that, perhaps, yes.
I'm really glad you asked that question about stop telling implied statements. Stop telling parents what to do necessarily. It's not that, like the moms I work with in the methadone clinic. It's not that they don't know that beating your child is not a good idea, right? Most of them will come and tell you, I'm trying to stop that. My God, I can't. I'm exhausted. So the one talks about putting newspapers on her baby because she doesn't have the money to buy diapers, and the other kid is in school getting suspended. These women are exhausted, emotionally exhausted. So I feel very strongly that telling parents what to do is not necessarily going to be our first line of action that's going to make a difference. At a policy level, it could happen at the national level, university level, or community level. But I'm very encouraged by Mayo Clinic. This is the CEO who's freed up 1 hour. There is beginning recognition that we need to do something for families, and we need to put our money where our respective mouths are.
Thank you. Yes.
Hi, Rick Barth from University of Maryland. Nancy, I had a question for you about the use of safe care. Are you familiar with Mark Cheffin's work in Oklahoma? He would claim, and there's a little publication and some panels about this, that safe care was actually quite well received culturally and was effective, but you didn't mention it, so I was curious about that. And Dr. Luthar, I was curious if you could help me connect a little bit better to the between the work on affluence and the 0 to 8 limits of our study, children 0 to 8, that would be very helpful because I didn't quite get that. Thank you.
So just in terms of safe care, the the home visiting evaluation report, there are a lot of programs out there that have different levels of evidence. They used a pretty high criteria for what qualifies as being an evidence-based practice, and Safe Care, I'd have to go look at that report to know what the reasons are that it didn't meet those criteria with American Indian population specifically, but that was what the report concluded. There are a lot of programs that there's some evidence, there are a lot of promising practices in home visitation. There are clearly a lot of evidence-based practices in general, just not the evidence-based with this population to see how they work. But Safe Care is one of those that is closest to that, absolutely.
Thank you again for asking that question. The answer is that the groups are meant for moms of kids from birth to adulthood, and I'd say about 80% or more of both sets of groups are mostly parents of younger children. So the relevance of my data or research on upper middle class kids is really to tell the moms, here's what's coming. To tell us, here's what's coming. Because the problems in the kids do not really emerge until middle school. That's when you start to see them. But thankfully, I was out at Palo Alto. There's been a string of suicides, high school suicides recently in the last year or so. And the audience there was not just parents of middle schoolers and high schoolers. There are a lot of moms there and dads who are now engaged. See, this is the beauty of this work. With low-income communities, you need money. With these communities, all you have to do, they're very bright, and the data speak to them. You show, this is what's happening, and this is what we need to do, and they listen.
Yes, Michael.
Michael Wald from the committee, and thank you all for your very helpful presentations. I have a particular question for Dr. Whitesell. You laid out a picture, which has been laid out for a long period of time, of really desperate need at both the child and the family level, and of the limited body of knowledge and the difficulties of actually gathering knowledge. I've done some work with Terry Cross in the Northwest Indian and funded some of that. And it's hard to get that research going for a lot of the reasons that you say. Given the level of need and the fact that we're very unlikely over any short period of time to have random controlled studies or a lot of evidence gathering, I wonder what your thoughts are of recommendations that might say we really ought to start at scale with our best guesses and then do a continuous improvement model on the services, rather than think we're going to get this out of a traditional research-based thing, that we can't wait more generations till that gets developed, and it seems like an unlikely scenario even over generations.
Yeah, I think that's exactly the strategy to take, and I think that's the strategy that's being taken with the maternal, infant, early childhood home visiting programs under the Affordable Care Act, is we don't know what works in tribal populations, but ACF is funding grantees to try something, and they can pick from the evidence-based list with other populations, they can pick from promising practices. The idea is to get something on the ground and try to address it, but there is a requirement that each grantee has to do a rigorous evaluation of some sort and contribute to that body of knowledge. And I think that's the way it's going to be built, is not, as you said, in the way we do in other populations, but by building that body of evidence that informs from different directions what works and what doesn't work. And I have to say the challenge there is it's hard to do a rigorous evaluation in a community that has 10 births a year in a group that's trying to serve that. But there are bits and pieces of evidence that can be pulled together to inform that big picture, but it's in a very different way than we usually think about building evidence. But I think it's a great model, and it's a great model for building capacity in the communities to think about not just implementing programs, but critically evaluating what they're doing to see if it really does work, and gathering some evidence in that continuous quality improvement vein to say what's working, what's not working, how do we adapt it, how do we move forward, how do we better serve these parents and children.
And if I might, there's other questions.
Yeah. There's just one more, and maybe if you have time, we can come back to you.
Yeah, right, yes.
Yes, ma'am.
Hi, I'm from California, and I work with child care resource and referral agencies, so working with parents seeking child care. this is a follow-up to the institutional question, because my experience is that parents feel that the institutional, it almost feels like it systematically breaks them down, their confidence. And so I was curious, Dr. Whitesell, one of on your slides that you had, the answers are here. And so there's something I was wondering if you could say more about that in terms of lifting up parents' confidence to play the role that they can for parenting.
Yeah, I mean, I think one of the things is we need to pay attention to that. We need to listen to what people in communities are saying they do and that works, and figure out ways. We talk a lot about practice-based evidence, not just evidence-based practice, and trying to understand what works and what in the case of the work I do, what the indigenous perspectives are, what kind of evidence they have that it works. Why are they saying this is the answer? What do they trust? And paying attention to that kind of evidence, not just our, as they see it, sort of fancy schmancy evidence from the outside, and listen to them and reinforce that. Yeah.
Thank you. Michael, do you have your... Well, I have questions, and we have time. So maybe, Suniya, a question. You alluded to this, but you said the risk factors are kind of similar with high income and low income families, and the intervention seems to work similar fashion, it seems like. But what are the consequences of being at risk? Like, using drugs or other things would have, I would imagine, very different consequences for low and high income kids because of other protective factors. You know what I'm talking about?
I absolutely do. In theory, yes, Selchuk, that you would imagine that children in upper middle class societies, because there's this plethora of services available to them hypothetically, that they would outgrow, it's not happening. We've got our longitudinal data. We've got the sample we've been following since they were 12 years old. They're now about 28. What was serious delinquency at the age of 14 or 16 mushrooms into antisocial personality diagnoses? What was binge drinking? There's like 1/3 of the sample. These data are not published. We're writing them up. 1/3 of these kids has a diagnosis of alcohol or substance abuse dependence. So they're not outgrowing them. And if you stop and think, I'm a child development person, I'm a developmentalist. If this has been going on from age 12 to age 18, pretty much unchecked, what is the likelihood it's going to stop? One. Number two, as I said, there's a great stigma against seeking help, not just among physicians, but among parents for their kids, because you don't want their records to be sullied. So much of the time, the parents are going to say, do what you can to keep it under wraps, and hopefully it'll go away. It doesn't.
Very interesting. And maybe follow up with the last question, and we'll take a break. Nancy, you mentioned that the numbers are so small, like 10 kids in one community, and you drive miles and hours to get another small group of people, which makes it very difficult to do intervention, to the research as well. So I wonder if the use of technology, I mean, we are now being broadcasted over there, some people join here, so are there any innovative practices of either intervention or research that uses all this technology that we all have access to now?
Yeah, that's a really interesting question. One of my colleagues put in a grant like 2 days ago, particularly focused on how can we take interventions to scale using technology. And one of the things we do find is American Indian communities are fast adopters of things like Facebook and internet, and there's a huge use of social media to stay connected in these rural communities. In an intervention we're doing, we're using a Facebook addition to it to try to connect the families between sessions and try to reinforce the messages that they're getting. I have colleagues that are using texting interventions, things like that. So there's definitely a lot of potential there. I think what the evidence that we have is what works best is some sort of hybrid. It's not just that internet platform or the texting platform is not going to do it without some sort of connection, but a hybrid where that supplements and maybe there's less frequent contact with that in between.
Thank you so much. Thanks for all the presentations and thanks for your questions.